Hi, good afternoon. This is Jana Tard. We are discussing the sepsis calculator. What does this mean? Well, we utilize this tool. It's a very important tool for the assessment, the monitoring, and the management of sepsis risk in newborns. I hope you have a good time. I hope you come along for the ride, and I hope you ride it all the way to the end. My disclaimer today, same as always, this is not perfect. This is my compilation of information that you can look at, you can process through, you can call me back, you can question, you can do your own due diligence, and then you can contact me back and say, this is the way we do it, and this is better, and this is why. So let's go ahead and let's save lives. Okay, let's make a difference. So, what are our objectives today? Well, first of all, my disclaimer again, I am not perfect. The program's not perfect. I am one individual who has practiced in the OB baby realm for greater than 40 years. I love it. I'm passionate. I care. I don't take adrenaline to the scene, but I take my unified, systematic, organized attention to detail that I've gained over time through standard of care, through practice and procedures, through hospital policy and objectives. So, what are we doing today? We're understanding sepsis. What does that mean? That means basically infection and infection risk. So, we're going to learn about this tool, and we're using it for neonatal sepsis risk based on factors. We're going to identify what I said before, which is called equivocal scenarios. So therefore, recognizing situations where sepsis risk assessment may be ambiguous or uncertain. We will learn what that means. We will recognize significant maternal risks. So identifying maternal conditions or situations that can increase the risk of neonatal sepsis. We're going to highlight the importance of assessment, evaluation, monitoring, and reporting, and identify each critical step along the way, circling back, talking to the team, collaborating, communicating, documenting, all along the way. We're emphasizing the importance of speaking with the family, educating the family, collaborating with the family, having them participate as eyes and ears on behalf of this baby when the baby is out in the room, which they do all the time after delivery, and emphasizing the medical legal implications without collaboration and documentation. This is important. This is real. This is our lives. So let's begin. So, early identification and prompt reporting of an infant with respiratory distress is crucial. The baby's born. Let's give ourselves an example here without even reading the screen. Mom has chorea. What does that mean? Temp of 100.4 or above for a persistent period of time. Had a really long and difficult labor. Heart rate increases in both the mom and the baby. The baby is born with some signs of late decelerations, and the baby comes out grunting and or with respiratory distress, a little bit of retractions. If that doesn't resolve right away and it persists for greater than equal to 4 hours after delivery, we are identifying this. We are reporting this. We are documenting this, telling the pediatrician, and then per the standard of care, the neonate is contacted to evaluate the baby. So what happens? We are a team of highly experienced nurses who closely monitor an infant, carefully observe the child's breathing and vital signs to determine if that child, in fact, needs to go to the NICU. Does the family get scared? Of course, but the other implication is an infant can turn quickly. So without prompt identification, early intervention, a baby can become very septic, and that is not something we want to have happen. The skill and experience of the medical professionals is important for the infant to regain stability and remain with the family. Okay. So, what is our duty? As I tell my students, as I tell myself, as I go to the hospital each and every day, and I pray upon entry and I pray when I leave, my duty is extremely high. and it is to evaluate these unbelievably gorgeous pieces of wealth, these babies, with or without equivocal status, making sure that for each and every child, whether they're stable or not, I am doing continuous monitoring, comprehensive assessment, timely reporting, collaborating with the team, pushing if I must, where some attorneys say, wait a minute, you're not the doctor. Well, we are the eyes and ears at the bedside, documenting and recording, pushing to get the baby up to the NICU if necessary for treatment. When you get that 1 out of 100 where they say, Jan, you made a difference. You got that baby to the NICU. You cared. Baby got antibiotics, and look, the baby's going home. The baby's a year, 2 years, 5 years, 10 years, and that baby is healthy and happy and dancing and jumping and playing. And we've educated that family. We've educated everyone on the team to do better, to be whole, to be thorough, to be thorough. That is our goal. So how do we evaluate? Well, we look at the delivery note. What happened? Okay. So what happened with the infant's birth? What was the gestational age? What was the birth weight? What were any complications? And what does that even mean? Was there MEC? Was there gestational diabetes? Was there hypertensive crisis? Was there no prenatal care? Were there drugs that involved in the delivery that affected this baby? Anything? Was there nuchal cord, meaning the cord was wrapped around the neck, potentially compromising oxygen supply, potentially causing an increase in stress interior to the baby without sufficient fluid wrapped around this baby. Maybe germs get into the fluid, causing an increase in the temperature. Things happen. With that, we look at the sepsis calculator at delivery. The absolutely fantastic, unbelievable, unmeasurably brilliant ALS nurses write their sepsis calculator notes. Within those notes are spelled out very, very specific criteria for which babies have reached what we call the equivocal status, where within that status, if a baby shows that, lower temperature, less than 97.4, persisting for a long period of time, high temperature, respiratory rate greater than 60 to 80 with retractions. We get screamed at by that baby with all those symptoms to say, please look at me. Please identify my risks. Please report. We have garnered the full picture of the baby. We've combined all the information. We've called the doctor. Please, doctor, call the neonatologist. Our thorough review and evaluation of the delivery note and the sepsis calculator is critical to provide the best care and outcome to this amazing baby. So what is this sepsis calculator? It's merely a tool. And it's a tool that is standardly utilized. And so based upon this, we plug in some figures, and what pops out is a number, a qualified number that we can utilize to make an assessment. Each nurse looks at things differently, but overall, we're evaluating the same. So it is a tool used to assess the probability of early onset sepsis in a newborn based upon maternal risk. The purpose is to reduce unnecessary antibiotic use while ensuring timely identification and treatment of at-risk babies. The key components are maternal risk factors, clinical status, and the calculation that I have just discussed. The maternal risks are factors related to the mother's health. Is she older? Is she in poor health? Has she had a difficult pregnancy? That increase risk, and the clinical status of the baby. Infant's current symptoms. And my goodness, babies are being born at 42 weeks, almost too long, 33 weeks, 32 weeks, 29 weeks. So we calculate risk stratification, and then we come up with this equation. It looks a little bit like this. There's pieces of this that are cut off, but we're taking a look at what are the weeks gestation, what is the temperature, is GBS positive or negative? Are we going to need to give broad spectrum antibiotics? And if the symptoms persist for greater than 4 hours, then this is considered. So per how many births, we're going to come up with this kind of a picture, and it's green, yellow, red. If we fall into this red category, or if we fall into this yellow category, we may be doing just blood cultures, we may be giving antibiotics. And this is determined by a collaboration of all this compendium of information, the final decision made by the neonatologist. So back to our duty. We acknowledge essential factors. We look at gestational age. We look at temp. We look at GBS. We look at rupture membranes. We look at presence of MEC. And if the baby is deemed equivocal by the changes in the respiratory rate or the temperature, or we look at the equivocal number first and then collaborate that with the baby's presenting symptoms, and then we scream out. And those of us who scream out, we know how to scream out. We've been doing it a long time. And so let's repeat. And as I said at the very beginning, I repeat a lot because I believe in spaced repetition. If I'm going to learn it at my age, I'm going to learn it once, but then I'm going to learn it again, and then I'm going to learn it again, and I'm going to learn it again, and I'm going to learn it again. So if you're still with me, hopefully by the end here, you're going to learn it like I learn it. And you're going to step into the nursery and you're going to be able to identify a baby with respiratory symptoms and say, what does the sepsis calculator say? Okay. What does the neonatologist say? What is going on with this baby? So again, we're using a tool to assess risk of sepsis. We're looking at equivocal scenarios that are based upon that number. We're looking at significant maternal risk, and based upon our assessment and valuation, we're looking at infant risk. Why? Because of the medical and legal complications and consequences and implications. Therefore, we collaborate, we communicate. Every day I go to work, I work with exceptional, exceptional, exceptional people. And so what is our role in life? Well, we define risk. We look at early onset sepsis. Our purpose is to reduce unnecessary antibiotic risk while ensuring timely identification and treatment. So our key components: maternal risk, clinical status, calculation of risk, all the time. So it is a compendium of things we look at, and then it is a team of people, never just one. Everyone has their eyes on this baby, and everybody cares. The sepsis calculator is a critical tool helping everyone, not just nurses, not just students, monitor and manage the risk of sepsis in newborns, ensuring timely and effective intervention to improve outcomes. Anyone who's had their baby in the NICU understands what I'm talking about. This is a very critical, but a very, very organized situation of people that save lives. So what are some of our risks? GBS positive, group beta strep, increases the risk of vertical transmission to the newborn. It could lead to potentially serious complications. What is choreo? It's an inflammation of the chorion and amnion membranes surrounding the baby, leading to an increased risk of infection transmission to the baby. What is prolonged rupture of membranes? Well, the mom comes in, the bag of waters ruptures, and the mom doesn't deliver for hours. If the hours increase greater than 18 hours, again, we're looking back at an increased risk of infection. Maternal fever, as I said before, anything elevated to equal to or greater than 100.4, watch out for infection. These maternal risks increase the likelihood of vertical transmission of infection to the newborn, requiring careful monitoring and appropriate interventions to ensure the well-being of the mother and the child. When I say vertical, what does that mean? Okay. it means up into the uterus, okay, from the outside, okay? Lots of bacteria, lots of things that can potentially cause increased harm to that baby. So back again to that word equivocal. Well, if a baby is born and the baby comes to me and that baby has a persistently low temp, my red sirens are going to go off, okay? Because low temp can be an increased sign of sepsis or serious infection. So what are we going to do? We're going to put the baby on the warming table. We might do a chem strip to check the baby's sugar. We call the pediatrician. We may transfer that baby to the NICU to go on fluids and D10 or whatever kind of fluid. Tachypnea, greater than or equal to 60, lasting equal to or greater than 4 hours. Tachypnea that results in retractions or grunting or flaring can also indicate respiratory distress or infection. Lethargy, poor feeding, irritability. These symptoms may also signal an underlying medical condition requiring immediate attention and may be signs of sepsis and infection as well. So back to what did I say? We're going to assess and identify and report and document any kind of changes. And those of us that live in this world, we're going to scream out and scream out and scream out because that's what we do. We're going to evaluate. We're going to watch this baby. We're not going to let this baby out of our sight. We're going to monitor and continuously observe for trends or worsening signs. We're going to report. Those doctors know me. They know people similar to me. The neonatologists know us, and they respond accordingly. And then we document because everything has to be documented. Everything has to be done. We all have to care. Back again. Equivocal, persistent low temperature, less than 97.2, tachypnea greater than 60, lethargy, poor feeding. It could be anything around these numbers. If I get anything close to this, my feelers go up. My role, identify early signs and symptoms of an equivocal situation. Again, my role, I'm comparing findings against the protocol and sepsis risk. I'm looking at this baby before and after. I'm looking at what was going on with the mom. My role, continuous observation for trends of worsening or improving symptoms, and I notify and notify and notify and document. Okay, I never ever stop. So back again, quickly assess, identify underlying causes. Okay, what's going on with that mom? What's happening with that baby? Initiate appropriate care, obtain diagnosis. If I need to push, I will. Get that baby where it needs to go. Prompt and comprehensive evaluation of an infant with respiratory distress is critical to identify the underlying cause and provide appropriate treatment to ensure the best possible outcome. Are we working in collaboration with a team of unbelievably educated and talented pediatricians and neonatologists? Yes, but we are the people with 600 babies born each month, with a kindergarten with 10 to 20 or more babies born each day. We are there at the bedside. We are watching these babies. We are the eyes and ears to report off to these physicians. So we have to care. We have to matter. We have to live for these babies. So the prompt evaluation of sepsis and the presence of persistent distress is absolutely critical and can save a life in every single situation, which is what we do. So again, GBS positive, have discussed it. Chorea, have discussed it. Prolonged rupture, maternal fever, have discussed it, okay? So the critical role of each and every dynamic team of nurse includes identification of sepsis on the sepsis calculator, maternal fever, prolonged rupture, and an infant with a low temperature. It says here prolonged rupture for 24 hours, but it's anything greater than 18. So, okay, so here we are. This case involves a maternal fever, prolonged rupture of 24 hours, and an infant with a low temperature of 96.9. So, the infant was evaluated at 2 hours of life for the presence of persistent tachypnea, 60s to 80s, with retractions. So, the discussion by the nurse team prompts a focus on immediate nursing actions, utilization of the sepsis calculator, and immediate communication and documentation. So, first of all, what would these young nurses do? Well, we would definitely warm up this baby. This baby is way too cold. Doesn't need to be in the room. Needs to be under a warmer, okay? Needs to be reported to the doctor. We need to check the sugar. Is this baby not eating? What's going on? We're at 2 hours of life and the breathing is 60s to 80s, way too high. With retractions, what could be happening? Fluid in the lungs. Are we going to get a chest x-ray? Are we going to immediately transfer this baby? Sometimes they want us to keep this baby and monitor in transition, okay? The discussion by the nursing team, okay? We are not just discussing on our own. We are discussing in collaboration with the physician team, because the physician team is the one that makes the final determinations of what to do. But we're looking at all these symptoms. We're trying to stabilize the baby. We're looking at the O2 saturation. We're looking at what is the heart rate of this baby. Do we notice any kind of fetal tachycardia? Do we notice any kind of murmurs? Do we notice any kind of fluid in the lungs? All of this is taken a look at collaboratively in one big picture. So the importance of chain of command and collaboration. This is what I've been talking about all along. It ensures critical findings are escalated appropriately. It enhances teamwork between the nurse, the very honored pediatricians, and the exceptional neonatologists. And the ALS team kind of works with everyone and they oversee, and they are just the people at the bedside that are doing most of the resuscitation. And they actually write up these sepsis calculators. We reduce any kind of delays in care that can lead to negative outcomes. We identify tachypnea and we alert the pediatrician and the neonatologist. Labs are ordered, antibiotics are ordered, and a baby is placed where they need to be placed. The neonatologist will review any and all trends and determine next steps. And of course, communicate with the family. They have to be first of mind. They have to know what's going on. So a scenario 1, maternal GBS positive without prophylactic antibiotics. Prolonged rupture, 20 hours. Infant born, APGARs 8 and 9. Infant presents, low temp, tachypnea, persists beyond 4 hours. What do we do? Well, we use the sepsis calculator. We determine risk. We notify the physician. We evaluation of CBC and blood culture. We document our findings and we escalate clear and complete steps. Okay, so that's what we would do. You question your own actions, please. Scenario 2, chorio, infection, persistent tachypnea. Okay, maternal fever, 102 during labor. Chorio, infant delivered vaginally, no resuscitation. Respiratory rate, 64 at 1 hour. Persisting beyond 4 hours. That word persistence beyond 4 hours turns on the red flag. Okay, red flag on. Okay, key nursing actions, document. Use the sepsis calculator. Notify the pediatrician. What is the O2 sat? What is the blood sugar? What does this baby look like? What is the entire picture? Call upon the neo to come down and evaluate for labs and x-ray. Timely action prevents potential injury. So We outline all important steps. We monitor, we manage. The sepsis calculator is a valuable tool. We treat, okay? We treat stable infants. We treat critically ill infants. We treat infants before they become critically ill because we identify sepsis early, and we work with families. We ensure the critical findings are escalated. We enhance teamwork. We reduce delay, and we enhance collaboration. Going back yet again, documentation is our shield. We use objective language. We use time-specific actions. We avoid speculation. We are factual, factual, factual. What is documented is done. Clear and comprehensive documentation supports my adherence to the standard of care, providing critical evidence in case of litigation. We are clear. We are objective, time-specific, no speculation, clear, and critical. The transition nurse is an exceptional role. She works hand in hand with the pediatrician, neonatologist, ALS, and everyone on the floor. We provide assessment. We provide sepsis risk understanding. We are the first point of communication. We timely identify and report. We make sure everyone knows how to use the sepsis calculator. We provide continuity of care, not only to the nurses, but to the family. Our key takeaways here: early recognition of risk. Use the sepsis calculator. Collaborate and be clear. Be thorough with these beautiful gems of babies. Our wealth, our everything. My everything. Everyone's everything. So early recognition, effective assessment, strong collaboration, detailed documentation, essential to fight against sepsis. So we do early assessment, we use the calculator, we serve as the first point, and we save lives. Okay? We save lives. The resilient child born with the strength to persevere is a testament to the incredible advancements in modern medicine and the dedication of care of medical professionals. We are blessed. So back again, early identification, reporting to the pediatrician, understanding what is sepsis risk, transfer to the NICU, good outcome, happy family, safe baby. So we love what we do. We perform with duty of care. I work with amazing colleagues. I owe everything to my amazing team. I thank you. Have a lovely day.